this was kind of like the MRAP, which is a entirely different thing, but the program seeming like an idea where the Army and the Congress can work together to do the right thing. We did in equipment. Now we're talking about our soldiers and how we take care of them. Now, you've made great strides, and I listened to what you and Senator Mikulski were saying about in recent years in suicide prevention. But last year's doubling of Army Guard suicide shows that the Army falls short when it comes to the needs of the Army Guard and Reserve. They don't have a base. They're not going back to a fort or a base where you can have the services on within a limited geographical area. In a state like Vermont, which has no active duty installations, the Guard uses its outreach program to reach out to personnel where they live in hometowns across the state. They may be a town like the one I live in with 1,500 people. They may be in one with 100 people, or they may be in a community like Burlington that has people available. And our own Adjutant General, Mike Doobie, whom I believe you know, told me that there have been many potential suicides that have been averted by this outreach. Now, the funds needed to preserve these programs are less than $10 million for the remainder of the fiscal year. Are these programs going to be funded for this year and for the future?
Well, sir, first of all, I want to thank you for the advocacy you showed for the 86th Infantry Brigade Combat Team that did deploy and then redeployed through Fort Drum. And I think illustrated the progress we've made in trying to bring back, redeploy, and then demobilize our Guard and Reserve. What you've highlighted, and other members of the committee have highlighted, are the problems that are inherent within the operationalization of the reserves. Our Guard and Reserve, which was within the Army, conceived of in past times as a strategic reserve ready to get launched one time for a major nation-threatening war or conflict, has now been, for the last 10 years, integrated fully into the deployment of the Army through an operational reserve. And in doing that, what we've identified are shortcomings and challenges in providing care for National Guard and Reserve soldiers and families when they get back to their communities.
And providing that care is a little bit different than going back to a base, going back to
no question
Fort Hood or somewhere else.
And the rules that govern access to that care are quite different. I mean, while the soldier is on active duty, if the soldier incurs an injury or an illness as a consequence of that deployment or that training to go to deployment, there's no question we have ready access to military units and military health care, and our TRICARE network for that matter. It does become a challenge when soldiers are redeployed, demobilized, and then sent back home, where they may face environments, and you're not alone in Vermont in facing this problem. I'm working very closely with the Guard and Reserve. I think one of the major efforts that Major General Rich Stone, who is a mobilized reservist himself out of Michigan, and a physician in practice, but has left his practice to work with us and orchestrate a program to look at how we can better support the Guard and Reserve. We've been looking for the last couple of years at exactly how we can better care for and reach out to the Guard and Reserve through TRICARE and other efforts. So we're looking at the programs that are threatened by the loss of funding, sir.
Well, please look carefully. Work with my office. You know, we've had, after redeployment, we talked about the Warrior Transition Program, and I know that there's a pilot program established at Fort Drum, which still has some issues to work out. It's far superior than what it was the 86 had before it, though. And I just would like to see these things around the country, because it's, when you've been in Iraq and you've been in Afghanistan, as I have, and you see these people on the field, you can't look at the soldiers going and say, well, that one's a Guard member, and that's you can't tell, nor are their duties any different. I have one other question, and actually I pass this out to all of you, General to you and Admiral Robinson, General Green. I've long supported improvements in military medical care through information technology and increased use of it. I've supported a military medical decision-making tool called CHART. The Office of Secretary of Defense plans to mandate for use by the services in pre- and post-deployment healthcare screening. A recent study by an Army doctor in the American Journal of Psychiatry linked deployment screenings to improve mental health outcomes. Are your services going to be using CHART, and what interface with your readiness systems? Admiral Robinson, would you like to
Sir,
take a swing at that one?
I'll take a swing at it. I'm not familiar with CHART, so I don't know whether we will be using it or not, but I can certainly take this for the record and get back to you.
Would you please?
I certainly will do that.
Thank you.
Sir, for the Army, I'm not familiar with that as well, but I will, this is a good point for me to make a pitch for this behavioral health system of care that Major General Horoho has taken personal leadership in. It allows us to look at programs like CHART or any other program in an objective way and do a head-to-head comparison with our existing systems and see if it delivers a better outcome. So I think we can take this on.
I mean, we all want the same thing. We want the best outcome, and I'm just pushing to make sure we have it. And General Green, and certainly all three of you feel, and please do, give me something for the record on this. General Green?
Yes, sir, and I'll take the question for record on the chart specific question. I would add that we now have almost 5 years of data from our electronic health record. And so leveraging the data that's in ALTA and basically linking that with the pharmacy transaction databases as well as the M2, we are now leveraging informatics to try and get to new levels of decision support that will really change medicine over time. I strongly believe that if we can get better information to the patient so that they make sound decisions, that we can then also get them to the healthcare team, which can augment and give them even further information, we will see tremendous change in medicine because we'll be able to pinpoint prevention back to what's necessary for the patient's care.
Take a look at this one, because, and take a look at any of the DOD directives on it, because there has to be follow-up to make it work, and that's what I'm most concerned about. I worry very, very much that some of these brave men and women we've deployed fall off the screen because they're not treated properly or whatnot. I don't pretend to be knowledgeable in this, but I know when my wife was working as a registered nurse, she saw a lot of these people that should have been helped. That was a different time. Should have been helped, could have been helped. And then I go to some places where the care is superb, and the person who might have committed suicide somewhere else or might have dropped off the screen somewhere else or had a debilitating illness that could have been corrected wasn't. And so we asked them to put their lives on the line, and I mean, you know that, and you believe that as I do, and I think we owe something when they come back. So let's see what this is going, let's see what the directives are, and let's see what the implementation might be.